Good morning and welcome to the 11th meeting of the Equalities and Human Rights Committee. I thank all members and witnesses for their attendance today in these very unusual circumstances. We're grateful to the Broadcasting Office for all their work in setting up this remote meeting of the committee. We are living in challenging times, and I know the committee wishes to pay tribute to all of the organisations in the equalities and human rights sector for their continued dedicated service and hard work at this time. Parliamentary scrutiny does continue, and we are very grateful to witnesses and others for finding the time to answer questions from the committee and for the way that they and other bodies responded so quickly to our call for views. Responses to our ongoing call for views are on our website. Our main item of business this morning is our third evidence session on how COVID-19 has impacted on equalities and human rights. We'll have two panels. I'd like to welcome our first witnesses on our panel this morning. Claire Cairns, Network Coordinator at the Coalition of Carers in Scotland. Heather Fiskin, Head of Policy and Research Team, Inclusion Scotland. And Kim Hartley-Keane, Head of the Royal College of Speech and Language Therapists Scotland Office. You're all very welcome this morning. And I refer members to paper 1, which is a private paper by Spice. This morning we're going to take questions in a pre-arranged order. I will invite members to ask questions and then invite witnesses to respond also in a pre-arranged order. If you have nothing to add to a question or answer, please don't feel the need to speak. You can simply state so. And I'll go back to each member for any follow-up questions. Once completed, I'll invite the next questioner and so on until the evidence session is concluded. I expect this panel's session to last for no more than 1 hour. We'll get the most out of this hour if we keep our questions and answers succinct. And if you allow broadcasting staff a few seconds to operate your microphones before beginning to ask your questions or provide an answer. So if I can begin with a question about communication. In respect to people who might have communication needs and require social care support, we have in legislation now provision on inclusive communication. How do we make sure that that has a positive impact on the lives of people who need that now? And if I could start with Claire, please. Claire.
Yes, in relation to carers with communication needs, we don't have a lot of data on that, to be honest with you. I mean, certainly more in terms of communication needs, we would see that carers who aren't able to access online have difficulties in terms of finding out accurate information, particularly older people, where most information is coming across through social media and online at the moment. But in terms of other communication needs, we don't have any information on that. So I think I'll pass over to Heather, who I think will have more information.
Thank you, Claire. Heather Fiskin, if I could come to you, please. Heather.
Thank you. This is a really, really important issue for many disabled people who have communication needs. I think the first thing to say is that communication isn't just about giving people information. It's about two-way communication. So it's all very well having information and guidance in accessible formats. You also have to make sure that the response to that is also accessible, that people can contact. There is an SMS service for people who have the shielding list so that they can contact and ask for support. That's useful for some people, not for others. The other recognition here is that there are so many different specific needs with required to accessible information. That it really has to be based on what works for that person. I think another thing to flag up here is that we have found that some of the communication that has been coming out in terms of guidance is coming out in English written format. And we've had to go to Scottish Government, to other people to say, no, you have to have this in easy read, and you have to have it in easy read at the same time. And also there's a big issue around access to IT and technology. Which ties in with poverty, people not being able to afford it, some of the more rural areas not having the right kind of network service. So all these things have to be taken into account. definitely legislation as a starting point is a good one, but there's lots to learn, there's lots to practice, and disabled people know best what happens and what works. And it's definitely not one size fits all. Thank you.
Thank you, that's really helpful. Kim Hartley-Keane, can I come to you now, please?
Good morning. Yes, thank you for this opportunity. I think in terms of who communication inclusion is important to, people living with communication disadvantage or communication needs are widespread and are being disproportionately impacted by the current crisis. As others have said, strongly associated with socioeconomic disadvantage, and that might be linked to literacy difficulties, literacy challenges that people experience with or without a identified communication support need. But we don't have any official stats at the moment on the total number of people in Scotland who experience communication needs on a day-to-day basis, which is a big gap, I suppose, and I'll come back to in a moment. But we know that everyone who has, and I know other witnesses have reported this, everyone who's on the has an autistic spectrum disorder, dementia, people experiencing mental illness, people with learning difficulties, 30% of people have had a stroke, and of course I know Deaf Scotland's made very good evidence about the 1 million deaf and hard of hearing people of all ages, and of course there's all those people with visual impairment. So we're talking about an awful lot of people, I suppose, and of course none of us, when we're frightened or in crisis, and we know that this has brought a lot of stress, are really up for being able to take on board complicated information. It's got to be clear, and we've got to be carefully listened to, and all our communication behaviours have to be attended to. In answer to your question, Ruth, I think you were asking what we should be doing about trying to meet those needs. I think there are things that have obviously, it's not that nothing's been done, there are good things that have happened, but as previous speakers have said, it's not all good. I think what we've seen is a lack of consistency. So I think what we want is for inclusive communication to be seen as a public health priority. Fundamental to any public health effort is people need to understand the issues, and they have to understand what to do to protect themselves, their families and their communities, and be able to ask questions, as Heather said, be able to communicate back to services. And it feels we're not necessarily making that big connection between how clear and accessible and inclusive the communication is and the outcomes for public health. The data tells us that there is an association between who is more likely to contract COVID and those groups with communication disadvantage, so poor people living in poverty, older people and people with disabilities. So first, take inclusive communication much more seriously as part of the public health effort. I think that's pretty fundamental. And having done that, certainly positively in the short term, I think it'd be helpful if government would just set out a requirement to expect all publicly funded agencies to implement current law and policy relating to inclusive communication. And I know that's something that, and use the existing resources that are already there. We've got excellent resources available on the Inclusive Communication Hub. We've got a whole workforce of speech and language therapists who are experts in inclusive communication. And there's lots and lots of information that's being provided by third sector organisations like the Stroke Association, for example, on how things can be done better, by Ideas for Ears and lots of other organisations. But I think it's, as I know Deaf Scotland said in their submission, and the committee has certainly asked questions of Scottish Government in its correspondence of the 4th of June, I think that it would be, going forward, Scotland needs to take a much more co-produced strategic approach to creating an inclusive communication nation. Not necessarily a consensus view across the sector, but certainly the Royal College of Speech and Language Therapists, Inclusion Scotland and Camp Hill Scotland certainly want to introduce inclusive communication law in Scotland. Others want a sustained strategic approach. So those are the things I think would be good to do. Sorry, it's not too short.
No, that was very helpful. Thank you. If I can bring in Alex Cole-Hamilton now, please, for his questions.
Thank you very much indeed, convener. Good morning, everybody. Thank you for coming to join us today, albeit virtually. I have a couple of questions around equalities impact and shielding, but I also have something that occurred to me, convener, which we didn't discuss in the pre-brief about testing, which I'd like to come in if you can bring me back in. So first and foremost, we've passed a lot of law in the foothills of this emergency. A lot of it's quite draconian. I think everybody would recognise the need for why, but sometimes I think when we do that, especially at such pace, it's easy to miss things like equality impact assessment. And a lot of the policies that we've enacted will particularly affect those with disabilities or other socially isolating protected characteristics. And I just wondered if you could each refer to whether you think we've done due diligence on equalities impact assessment, whether you think there are big omissions in that, particularly around the 2 coronavirus acts that we passed.
Thank you. And if we could come to Claire first, please, Claire.
Yes, I think carers have been particularly impacted by this. Obviously, many carers are looking after shielded people. It's been done around the impacts that's had on carers. So some of the, certainly the national care organisations, we've been looking at various ways to look at how this has impacted on carers. Carers UK have done a couple of excellent surveys, including surveying over 1,000 carers in Scotland within that, and we are in contact with carers centres and carers directly as well through social media. So a few of the impacts that are current for carers, certainly carers have additional caring responsibilities over this period. Because so many services have been halted, quite a lot of care workers are also self-isolating or shielding, which means that they're not able to get the support that they need. And this has quite an impact on many areas of carers' lives. In particular, if you look at the impact of carers' health and well-being, the Carers UK survey found that more than half of carers felt they were at breaking point. So I think really to look at the impact of carers both at the moment and also long term in terms of their health. And as we everybody starts to move slightly out of lockdown and restrictions are eased, I think it's very important to look at people who won't have the same freedoms as other people currently have and will have in the future. And just to ensure that, as soon as possible, carers' rights are brought back and services are brought back safely so that carers can be supported and also disabled people in that way.
Thank you. Heather, if we could bring you on an Alex question about equality impact assessments, please. Heather.
Thank you. That's a really interesting question. Equality impact assessments are really, really important. They're an important thing that we should do, especially at a time like this. But as has been recognised, things are coming at such a rate of knots that it's really hard to catch up and keep up with it. We've been very grateful in Inclusion Scotland for the opportunity to comment on several pieces of guidance, etc., that have been coming out as to do equality impact assessments. However, we're asked to do them at very, very short notice when we actually have a huge amount of work at the moment, as you can imagine. And we do them. But ideally, in an ideal world, we would go out and talk to our members. We would do quite a lot of work on it. And this just isn't possible at this time. And we recognise why that is, because people, especially for shielding, people are really crying out for the guidance that they need. And that goes not just for people who have the shielding letter, but for people who are shielding themselves based on their own expertise of their own lives and their conditions and their personal circumstances. I think it's worthwhile saying that one of the things about equality impact assessments is as part of the public sector equality duty, the review of that has been delayed, and we hope that that will be picked up as soon as possible. And really, it's just very hard to give due diligence to it at this time, as we would want to, but it must continue. Certainly as disabled people's organisations, we have a wealth of knowledge and the lived experience of disabled people that we can put forward. In a better world, at better times, we'll be going out and talking to people specifically, but we can't do that just now. Thank you.
Thank you. Kim, do you have anything to add on equality impact assessments?
Yes, thank you. I have to say that we haven't, and I'm not aware of other organisations who have worked with being asked to comment on equality impact assessments, so I can't answer the question about due diligence. I suppose it exposes that there isn't a strategic and consistent approach to communication inclusion. There's no regulated, co-produced quality standard, and I think if we had that, then quality impact assessment in relation to people that were experiencing communication disadvantage would be covered already centrally, rather than that repeating messages. So no, I don't know how diligent it's been, Alex, but Mr. Cole-Hamilton, but I do think that there's a gap there in terms of people with communication support needs.
Thank you. Alex.
I'm always happy to be referred to as Alex, so that's fine. I'll just quickly ask my question about testing, and then if you can bring me again, if there's time, convener, on shielding. I ask about testing because I think, of all the sort of policy shifts, the testing landscape is the most volatile. And it's very easy for us in the Scottish Parliament to ask for and then receive commitments to, say, for example, testing throughout care homes or testing throughout all residential care units. But we often forget that might mean testing very, very vulnerable people, many with cognitive impairment, and that might be people with dementia in care homes or people with profound learning disabilities in adult residential homes. And I don't think we stop to think about what that means in terms of the physicality. I've had 2 coronavirus tests. They are brutal. They're very traumatic things. And can I just ask what if you picked up any of this kind of sort of soundings from your members or your the groups you work with, from either groups, any group that has cognitive impairment, that for whom this is a real impact, and what can we do to kind of lessen the trauma for these groups of the testing regimes?
Claire, can I bring you in on this, please?
Yes, this has become an issue more for carers recently, I think, just in terms that there is, as part of the easing of lockdown, daycare and respite services are looking to open up again, and a lot of carers are asking about testing around that. Certainly we have had some anecdotal evidence that whenever people go for tests, they felt that there wasn't enough guidance around how to actually apply the test to themselves. This was in the drive-in testing, and people found it quite difficult. So I think that's something that could be looked at, certainly. But most of our evidence would come from carers themselves, who are also able to get tested now. And so unfortunately, we don't have as much evidence around people with cognitive difficulties in testing because our area is more carers.
Thank you. Heather, can I bring you in on that?
There's 2 elements to the answer I'm going to give. First of all, recognising what was said about the trauma of testing, and it's a very, very difficult one to answer. It's not something I have any evidence on, but I suppose the answer really would be that people have to be supported. They also have to have the choice, as much as that is possible. The other point, though, is that there are so many people who are not able to access those tests. We have an example from somebody we know who supports a young lady in St. Bruce in Galway, and she does not have a shielding letter from the Chief Medical Officer, but it's well recognised by everybody who knows her that if she does contract COVID-19, that she will not survive it. However, she cannot get her PAs tested, and that is the guidance from Scottish Government, that a PA can only get tested if they have symptoms. So basically, she is playing Russian roulette, if you like, with her life every time PAs come in, because she cannot get them tested until they are shown symptoms. And we know that not everybody is showing symptoms. And we also know that care workers are contracting COVID-19 very sadly. They're one of the highest professions with fatality rates in Scotland. I think it was 13.6 per 100,000 of the population, which came from the National Records for Scotland. So I've gone slightly off track with that question, but I think it's a really important thing to raise, that people can't get tested. And that's quite quite obviously as big an issue as the trauma of being tested. Thank you.
Thank you. Kim, I'm not sure if that's something you would have anything to comment on.
No, nothing to add on that.
Thank you. If I can bring in Angela Constance now, please. Angela.
Thank you, Convener, and good morning to the panel. I have some questions with respect to social care. Committee has received evidence that some health and care partnerships have raised the eligibility bar. Therefore, some packages have been reduced or stopped. So firstly, can I ask the panel, is this, in your experience, a widespread practice, or is it specific to some localities? Secondly, how is the assessment process working? Is the voice of the service user being heard? What's the impact on carers? And finally, what would help? What further action do you need from both the Scottish Government and health and social care partnerships now? Thank you, Convener.
Thanks. Claire.
Yes, in terms of eligibility rising, that's something that's been happening pre-COVID-19. In addition, whenever the changes to legislation came out, it seemed like quite a few health and social care partnerships started to look at people's packages at that point and reduce them. And obviously some of that was related to services having to cease or them having to deploy staff elsewhere. But it did cause a lot of anxiety amongst people, and still does, in the sense that will their packages be reinstated afterwards? There is some anecdotal evidence that people are hearing from partnerships that they may not be reinstated to the full package they had before. Others are reassuring and saying that they will be. I know it's something that the Scottish Government is looking at and I think needs to continue to look at. In terms of packages during COVID-19, for a lot of people, they are receiving no services at the moment, and that's due to a combination of factors. Firstly, like I say, anything building-based was mostly shut down during the period, although a few local authorities did carry on throughout and introduced measures quite early on, which was very helpful for people. For other people who were using, for example, direct payments and employing PAs, in some cases they were shielding and weren't able to continue to work, which meant they lost those services. And some carers chose not to use any services during this time, or disabled people, because they were afraid of the additional risk. So as I said before, what that has meant is in many cases carers are caring full-time, 24 hours for people with no breaks in quite intense circumstances. And there are many impacts that's having on their health and well-being and their feeling of being at breaking point. And as services potentially start to open up again, people are having to make difficult decisions about whether they will use them or not. And so I think providers are looking at all risk assessments, etc. But it's crucial that carers feel safe in terms of using services again. Other things that can help during this period, particularly around people with direct payments, guidance was introduced by government mid-May around people being able to use direct payments more flexibly, and that's really important. But we did some research recently, it's ongoing, we've had approximately 100 responses from carers on this issue, and the survey's still open. And what we found from that was 60% of people who responded didn't know that they should be able to use SDS more flexibly during this time, to maybe purchase items or equipment or employ a relative. And when we asked those who did know about it where they'd found that information, only 9% had been told by their local authority they could potentially use their direct payment in a different way. So we think that needs to be looked at. There are other ways people can be supported other than traditional services. We know, for example, that some of the grants available to carers have been very well used during this time to enable people to purchase different forms of support. So quite a long answer, but in combination, I think more needs to be done now, and then we need to look at what happens after lockdown.
Thank you, that's helpful. Heather.
Thank you. I'll try and build on what Claire said rather than repeating it. This is a really, really important issue. The first thing to say is how widespread is it? We don't know. I think that's one of the things that people have to gather the information on. What we do have is anecdotal evidence. We did a survey, over 800 people responded to it. of all the people who responded to the question about social care, 45%, almost half, said that their social care support had been stopped or reduced, sometimes suddenly, overnight, with no notice whatsoever, no advice about what to do in the interim period, etc. The impact of this, as you can imagine, is absolutely profound on disabled people and their households. We find that quite often, maybe elderly parents are having to start caring when they themselves have disabilities. People don't know what to do. They don't know where to turn to. They're still being charged or being asked to make contributions for their social care. They are struggling to access food and medicine, etc. Clearly, this survey took place in April, and some things have moved on and improved since then. But the isolation and the not knowing, and at that time we knew that people were being left basically living in their beds without any hope of getting out of bed for the foreseeable future. As you can imagine, it's a horrible situation for people to be in. And this fear and isolation is actually leading to a mental health crisis. People were reporting, many people who responded to our survey said they really were at the end of their tether. 15 of the people who responded actually opened up and told us that they were suicidal at the time of completing that survey. It was anonymous. We did put out information to tell people where to go to, but we couldn't contact them directly, unfortunately. So I suppose in response to this, first thing that has to happen is care has to be reinstated by any means possible. That we need to collect the information about how widespread this is in order to plan for that. And we need to look to the future and see what we're going to do. I don't think this is going to be the last time we're hit with this level of emergency. We know that the climate emergency is climbing up the agenda, that it is potentially getting closer to the point where we're going to have things like this happen. So the other thing we would ask is that charges are dropped immediately so that people can use that money to pay for other services and to help them make up for the shortfall in social care. Thank you.
Angela, has that covered what you were asking? Do you have any follow-up for?
No, thank you, Convener. That's covered everything. There was some really good pointers there, in particular about social care charging. I'm sure we'll come back to that.
Thank you. Can I bring in Maurice now, please? Oh, sorry. Forgive me. Just realised that I've not given Kim a chance to respond to Angela's questions. Apologies, Kim. We can come to you on that.
Thank you very much. I do have key points to make about this. Social care is a multidisciplinary effort. It's about health and social care, and we definitely do have statistics on what's happened in relation to the provision of speech and language therapy, who work with people with communication disabilities, but also eating, drinking and swallowing. That's the capacity to take in food and have nutrition. In a survey which was representative of therapists in Scotland in the final week of April, 92.8% of therapists said COVID had impacted on their services, and 75% said that some individuals on their caseload were not receiving intervention. And the reasons for that, just to back up some of the comments from earlier witnesses, it was as a result of changes to service because of national guidance, closure of usual place of work, that clients didn't want us to continue to intervene at the current time, or they didn't have access to telehealth, to near me type facilities. And there were also risks associated with aerosol generating procedures, which meant that therapists weren't able to get access, because they're not the procedures aren't listed on those procedures that require top level PPE. Therapists were doing risk assessments and deciding that it wasn't going to be appropriate for them to go in. So I think in terms of the widespread practice, yes, certainly in the section of the multidisciplinary team I know about. What would help? I think we need to remember health and care services are a multidisciplinary service. that AHPs, speech and language therapists, as well as our doctor and nurses colleagues, have to be involved in the return to care and opening up those services. At the moment, there isn't that engagement with the people providing those broader services to people. And I think that we need to work much harder at making sure digital inclusion works or is much more widespread. But I suppose the primary call is not limiting, thinking of the whole healthcare package that people need and making sure that that is accessible, because these are essential services, not luxuries.
On that note, can I just ask for a bit more information about what that would mean to an individual to not be having their speech and language therapy? I mean, you spoke there about the importance for food and drink for some patients. Can you expand on that a bit, please?
Yes. The incidence of eating, drinking, swallowing needs in care homes is enormous. Eating, drinking, swallowing needs will be experienced by everybody who experiences dementia, and it's a common issue for the frail elderly. Care workers get guidance and support from speech and language therapists following assessment on how they can improve or how they can minimise choking, coughing during eating and drinking and meal times, what to do in order to maintain people's nutrition. So without that access to that support, you can imagine the obvious issues that arise in terms of people maintaining their health, the distress that occurs around meal times. So I think in a crisis situation, eating, drinking and swallowing is obviously absolutely vital. And of course, the distress is managed. Distress or expressions of distress are communications, and you can reduce distress by enabling people to understand what's going on and enabling them to express themselves in ways that are less challenging to services. So the communication between the individual and those around them is absolutely crucial to safe and quality care.
Thank you, that's very helpful. Maurice, if I can come to you now, please.
Thank you, Convener. I'm just wondering from the panel's views on the different impacts between men and women, different age groups, the LGBT community or ethnic minorities.
Claire, if we could come to you, please.
Yeah, certainly there are impacts for particular groups when you're looking at the caring population. We know obviously that women tend to have caring roles more than men, so it tends to be about 60-40 in that respect. So if you look at the impacts for carers during this time, we know that carers are caring for additional hours and quite often trying to combine those caring responsibilities with employment. So that's another impact on women in terms of their economic viability too at this point, which is quite difficult. A lot of carers are older, and so particularly when they don't receive the support they used to at this point, there's even more impacts on their own health and well-being. And quite a lot of older carers, for example, caring for a spouse or caring for an adult with a learning disability, where they maybe used to go to daycare or used to attend a disability resource centre, those at the moment aren't meeting, which means that they're caring for them around the clock. I know at the Carers Cross-Party Working Group last week, we did have evidence from one of the organisations that support older people, just on the particular impacts for carers who are in that age group in terms of exhaustion and isolation. Those would be two things that they are particularly suffering at the moment. So again, as soon as services can open up, such as daycare, I think that is crucial that happens as soon as possible. Another area I'll touch on is carers from the ME communities. We think they are being under-supported. That's the evidence that we are getting, particularly in relation to communication. I mean, at the moment there is almost an avalanche of communication that's coming out, and certainly in the national care organisations, we're trying to make sure that, for example, local carer centres have the essential information they need for carers, and ourselves and MECOP run a BME carers forum for organisations that support BME carers, but it's very inconsistent across Scotland. There are very few specialist workers in this area. It's not something that's very often funded. So we know there are huge gaps in this area. And although there is nationally some generic information for people from BME communities, we don't know if there's anything specific for carers from BME communities. We feel like that's a gap. And perhaps one measure we think should be taken is the newly established expert group looking at BME communities. As far as we know, it doesn't have a representative for carers at the moment, and we think that that is a gap that should be filled. So yeah, just those in particular impacts for carers from different communities.
Thank you. Heather.
I would agree with Claire's last point there. It's something that we do need to spend more time on. At the moment, we are in a bit of an emergency response. What I would add to that, however, is some of the information I do have with me today relates to young people, age as a characteristic. And we know that of young disabled people, 44% of them aged 16 to 24 are likely to live in poverty. Now, this is an issue when it comes to COVID-19 because we know that people living in poverty in areas of multiple deprivation are more likely to contract and die of COVID-19. And we also know that, as Claire said, there's evidence that COVID is affecting people from the AME communities more so than other communities. Clearly, this is an area that needs more work. I would flag up, however, that we have recently published a piece of research called Services for Who, a small sample size, which looks at how disabled people with other characteristics are accessing services. Many of the people who spoke to us had comments on health services and how they felt that there could be race, could be other characteristics, and their disability impacted on how they were treated by medical professionals and the access to health that they received. And we know that this epidemic is hardwiring, if you like, health inequalities that already exist. If I could digress ever so slightly, we know from England, from the organisation called ManCap, which is an organisation for people with learning disabilities, that those with learning disabilities are disproportionately likely to be dying of COVID. Yet we cannot find that statistic for Scotland because it hasn't been broken down. The evidence that's coming out from National Records and Public Health Scotland is saying how many people are dying of whether COVID-19 and did they have an underlying health condition. But that's not telling us about access to health for people with learning disabilities, people who have a mental health issue, but wouldn't necessarily mean they would be more likely to die of COVID-19, but they are. And we need to get to grips with the data around this and look at it as soon as possible after this, as soon as possible, really. Thank you.
Thank you. I think the committee would be very interested to read the work on Services for You if you were able to share it with us, Heather. Thank you. Kim, can I bring you in on Maurice's question there about the impacts on different equality groups, please?
Yes, the link between communication needs and those groups is, well, let me start again. Communication disadvantage is experienced by people who are disproportionately represented among those people who are living in poverty, older people, people with disabilities. And therefore, and we already know that in those people are more, or we've already stated that people with communication disadvantage and living in poverty and with digital exclusion are more likely to be impacted by COVID. And we've heard from the previous witnesses that communication access, communication inclusion to the information, guidance, advice and services is not as we might want. So yeah, there are the impacts.
Thank you. Maurice, are you content? Do you have a follow-up for you? Content?
Oh, I'm happy with the views. Thanks.
Okay, thank you. If I could come to Alison now, please.
Good morning, panel. What else should the Scottish Government be doing to mitigate the impact of the lockdown and COVID-19 for disabled people and their carers?
Claire, can we come to you?
The National Care Organisation have produced a paper on this, Leaving Lockdown. We've worked with carers directly on it. We've had several meetings where we've consulted with people on it. We've worked with carer centre managers on it as well, just to set forward what needs to happen both now but as restrictions ease, and put forward solutions to some of the impacts that have already been felt by carers. So I'll kind of quickly run through some of the measures that we've set within that paper. The first thing to say is there's two principles that we think are very important. One, that carers are involved at every stage in terms of decisions that are made that have impact on them, because we've seen a bit less carer consultation and engagement during this process, and we think at times when big decisions are being made about social care services, it's even more important to involve carers. Secondly, that their rights are reinstated as soon as possible. Some of the rights of the Carers Act have been suspended, and we think as soon as possible they need to be reinstated. But some of the other solutions just now would be to ensure the SDS guidance is applied. I spoke earlier about SDS carers should be able to use it more flexibly now, but that isn't happening in every area, so that needs to be looked at. Starting up daycare and respite services as soon as possible, but safely, obviously, and making sure that carers feel they are safe to use. Supporting carers with practical issues like shopping, and Northern Ireland's done some really good work in that area. Particularly looking at directing support to shielded people and their carers, so trying to do some wraparound support for them as much as possible. Looking at specific information, because I think as things move on and not everybody gets the same level of freedom as other people, information needs to be more nuanced so that people understand what they can and can't do and are able to make risk-based decisions. We think there needs to be broadband for people shielding and devices if they don't have access to them at the moment, both in terms of their mental well-being and connection to the outside world and getting appropriate information. Access to health services being reinstated, we think that's crucial as well. And then as lockdown begins to ease, things like when the furlough scheme ends, there needs to be other forms of financial support for carers who can't return to work, and priority given to replacement care to enable people to return to work, because until that's in place, then they won't be able to. And guidance as well for employers in terms of supporting carers in the workplace. I mean, there is more to the paper than that, but I'll not go on, but certainly it looks at the many areas where carers are impacted and tries to have measures in terms of supporting them as lockdown eases.
Thank you, that's very helpful. Heather.
Thank you. This is a very wide question. I think one of the things Scottish Government and everybody has to do is recognise where disabled people were at the start of this, because that will help to drive how they address what they're going to do with the health inequalities that I spoke about, lack of accessible information. Lockdown isn't actually a new experience for disabled people. A lot of disabled people have been in lockdown for years. Inaccessible housing or housing you can't get out of, lack of social care that turns up at 6 o'clock in the evening, etc., to put you into your pyjamas, the employment gap, and all that means for income and benefits, etc. So moving on to what they can actually do now in the immediate period, obviously we talked about social care and reinstating that, ceasing charges for that. I mean, there has been investment in social care. We should recognise the things that Scottish Government have done, of course, but local authorities are not necessarily stopping the charging that's going on. They should also recognise risk. I think that has to be something that shapes the way that they address this. Right from the beginning, it's all been about what you can do for the vulnerable people, for the disabled people, etc. But disabled people are employers as well. Disabled people are carers. And it's not about just having this set of guidance for you, whoever that is, and vulnerable people just doesn't work. That has to be guidance for everybody. Still recognising the risk of where that puts people in the great scheme of things, and recognising that people might not necessarily be at any more risk of contracting COVID-19 than the next person. What they are at risk of is the responses to it, and the lockdown without access to food, so to speak. So the other thing is that as we move forward, we know 180,000 people have got the shielding letter, but we don't actually know how many people are choosing to self-isolate, self-shield without that shielding letter. And it's really important that Scottish Government reaches out to them and addresses their needs, and that these people aren't, if you like, warehoused. I always remember once reading a letter in the newspaper from somebody about why we're spending all this money on making public transport accessible for disabled people. They never use transport. Oh well, go figure. That of course is because the transport wasn't accessible, so people are stuck at home, shielding, etc. Nobody's conscious of them. They do have a voice, and that voice must be listened to. They really need that support for self-isolating. Some of that will be guidance specific to their conditions. I gave an example earlier on of a young lady, and the guidance that is coming out all relates to the conditions that make you eligible for a shielding letter. But what about the people who are self-isolating? The other thing that has to happen is that disabled people must be involved in setting what the priorities are, identifying what needs to be done, and shaping those services, etc. And in the future, we have to change the way we talk about these things, about the vulnerable, and so on. We have to start talking about everybody. We have to gather that data, and we have to start thinking about this in a human rights lens. Thank you.
Thank you. Kim, do you have anything you wish to add on Alison's question there, Kim?
Yeah, 3 points. First point, I think we need to ask inclusive communication has to be seen as a public health priority, both in terms of physical health and mental health, and it needs to be stated as a public health priority by government. In the short term, set out requirements for all public funded agencies to implement the current law and policies relating to inclusive communication, and that means that would look like identifying executive leaders, both in Scottish Government and at local authority level, on communication inclusion, to demonstrate that they acknowledge that every community or group includes people with different communication strengths and needs. Gathering information about actual and potential, how actual and potential users want to receive, understand and express themselves. We already have a lot of that data, so Scottish Government clearly co-producing, setting a standard based on what we know people want to see happen, and part of the requirement, expecting and requiring both Scottish Government and national and local agencies to use existing resources better, like the Inclusive Communication Hub and the knowledge and skills of speech and language therapists. And so that was number 2. That short set out a requirement to use what's there already in the law. And number 3 is to commit to co-producing a much more strategic and sustained approach to inclusive communication in the longer term. And as I said, consideration of introducing an inclusive communication law in Scotland would be incredibly welcome for many.
Thank you. That's really helpful. Fulton, can I bring you in, please, for your question?
Yeah, thanks, convener, and good morning, panel. I wanted to have a quick question about shielding. Roughly what proportion of the people your organisations support are in the shielding category? And what more, I know we've talked a wee bit about this, but if we could home in on what more do you think the Scottish Government could do to provide advice so that informed choices can be made, and how can they best do that for your individual groups? Thank you.
Claire, yes, anything further to add on shielding? I wonder as well, while you're answering that, it might be helpful for the committee to know if it's affecting different groups differently, younger and older people, those in rural and urban communities.
Yes, in terms of shielding, I suppose a smaller proportion of the caring population would be shielding themselves. Certainly some people are caring and also shielding at the same time because they are more at risk. But it would be much more common, obviously, for carers to be looking after somebody who is shielding, and that would be a large majority of carers who are either looking after somebody who is shielding or who are more at risk. So that would be a large number. In terms of information for shielded people, I think I said already that I think as restrictions ease, but they don't necessarily as much for shielded people, we need more specific information for people. But I also take Heather's point, which I think is really important, that for carers, that you can't put them into neat boxes. So carers won't just be looking at information for the people they look after or for caring situations. You know, carers are also parents. They're also sometimes employed. So they're looking at information about those aspects as well. And I think it's forming the links between the two. So if you're giving advice to people who are shielding and their carers to say, you know, you need to stay in the house for longer, then how does that impact whenever a carer's employer wants them to go back to work, or when they're being told that they have to homeschool their children? You know, all these things have to be looked at together. And I think I said before, it's a bit of an information tsunami at the moment. It's really difficult. So it is really difficult to get those nuanced messages. Like I say, we're doing our best. And what we find works best is guidance is really important, but people want it reduced into simple messaging. People don't have enough time to read large government documents. So we use a lot of social media infographics and polling, etc., for people just to try and give them bites of information when they need it. But it is by no means a perfect system. And I think it's very difficult for people to keep up to date with everything. So that would be one point. In terms of how it impacts on specific groups, one group I've not mentioned so far is young carers, and the impacts it has on them, and particularly for young carers, the impacts on their education, which at the moment it's more difficult for young carers to study at home. And as schools potentially go back in August, it will be difficult for young carers potentially to try and combine their caring responsibilities at home with their schoolwork. So I think it's something which needs a wee bit more thought in terms of education and how young carers are impacted, and looking at guidance specifically for them and work with schools to ensure young carers are supported. You mentioned rural areas as well. We have a rural and remote carers working group, which meets several times a year, and we've been keeping in touch with them during this period. And there are obviously particular challenges for carers in rural communities. So there's always been difficulties in terms of getting support to those communities, but to be honest with you, it's more of a level playing field because it's difficult for everybody to get support now. But as we kind of move out of lockdown or services start to open again, then things like transport will be particularly difficult. So if you're talking about services opening up, and normally people would attend, for example, the day centre and be picked up on a minibus, that might not necessarily be the case anymore, and that might be a barrier towards people accessing that service. So those are just a few things in terms of impacts for shielded people and carers in general. But like I say, the Leaving Lockdown paper we've put together by the national care organisations provides a lot more detail on all these issues.
Thank you. And again, it would be excellent if you could share that with the committee. We'd appreciate that paper. Heather, can I come to you now on the question around shielding from Thornton? They're your main concerns for disabled people, and I guess you've already mentioned as well that some people are shielding themselves. The other thing we're interested in is how it's affecting different groups differently, so younger and older people and those in urban and rural parts. Heather.
Yes, that's right. I should start by saying that Inclusion Scotland doesn't actually support individual disabled people. We're an organisation of disabled people and disabled people's organisations across Scotland. So I don't actually have a figure that tells me about the proportion of our members or partners who are shielding. What I can say, however, is to go back to the point I made earlier about shielding not just being about those people who have got the letter from the Chief Medical Officer. A lot of other people are shielding as well, and they're doing so without that equivalent level of support, and they do need it. To recap, and some of the things I've already mentioned very briefly, the support that comes with that shielding letter is things like access to food, access to being able to contact somebody and say, I've been caught short, I need help from a local authority or other supplier, information and how you return to work if you don't have a shielding letter, which could entitle you to statutory sick pay, etc. But you know that you will be at risk of illness or making somebody in your household who's disabled ill if you do return to work. Guidance for disabled people who are themselves employers, we are not all employees. Involvement in specific guidance that comes around. And also, most importantly, isolation. I mean, 12 weeks is a long time. And people's mental health and well-being. And how can people begin to go back out again safely? What space is there for this? But it's interesting we're talking about changes because we have found it ironic, actually, that since this epidemic has started, some of the changes that disabled people have been asking for years, like remote working practices and online resources and accessible information, is suddenly possible. And also proper investment in social care. And this discussion potentially about social care, people's commission to look at a social care service, but we have a people-led policy panel already in place for that. But it is somewhat ironic that these changes are coming about as a result of such a disaster, and this would put disabled people on a back foot right at the beginning. So to sum up, really it's about all people who are shielding, not just those who have a shielding letter.
Thank you. And I think that the point you make about the things that disabled people have been campaigning for ages for is very well made, and we need to make sure that we don't step back from that in terms of flexible working and online things. Kim, can I come to you on that question around shielding?
I am afraid I don't have data on the proportion of people that we're working with who are shielding. Shielding is needed though by a lot of people that, or shielding is happening for a lot of people that speech and language therapists work with, including really elderly, people with dementia, people with respiratory issues such as people with MND and MS. I don't really feel I can add anything more to the answers that have been given by previous panel members. Thank you.
Thank you very much. So that completes our question and concludes our first panel. And we've managed to get a lot in that hour. Thank you very much for your evidence with us. If the witnesses can wait for broadcasting to switch off your video and microphone, you're then free to leave the meeting. You can continue to watch if you wish to do so on Scottish Parliament TV. We'll now suspend briefly while we change panels. Thank you. Welcome back and good morning to witnesses on our second panel. Carolyn Lochhead, Head of Communications and Public Affairs, Scottish Association for Mental Health, and Catherine Lindsay, Convener, Social Work Scotland. Can I repeat my thanks to you for being here this morning? I'm grateful to you for finding the time to answer questions from the committee. If I can just quickly recap how this will all work. We're going to have the questions in a pre-arranged order. I'll invite members to ask questions, then I'll invite the witnesses to respond. I'll then go back to each member for follow-up questions. Repeat the request to keep questions and answers succinct, and please give broadcasting a couple of seconds to operate your microphones before beginning to ask your question or providing your answer. And if I can go straight to Alex Cole-Hamilton for the first question, please. Alex.
Thank you very much indeed, Convener. Obviously, we had a range of legislation passed at the start of the crisis. The Coronavirus Scotland Bill, the first one, had within it some pretty draconian measures, not least, and we all understood the necessity for these, but changes to legislation around mental health, particularly the requirement for a second medical health practitioner to sign off a recommendation to have somebody move to detention. Similarly, the period for which people could be detained was to be doubled. Now, these have not yet been enacted, but they're still very much live within the law. Do you feel that those were justified? I'm asking this to all the panelists. Do you think those provisions in Section 9 were justified? Can you see a time when they may still be required? Or do you think it's now time that, because we can see that the strain on the NHS is not quite what we feared, that we could stand them down and repeal them?
Thank you, Alex. If I can come to Carolyn first, please.
Thank you. So the question was about the emergency legislation, and yeah, we were prepared to support it at the time when it was introduced. We understood that it was an unprecedented situation. However, we had concerns in particular about how, if the powers were going to be used, how that decision would be taken, what actually the trigger point would be, and how then the decision would be taken to revoke them. We called for a scrutiny group to be set up, and we were pleased that that happened. And indeed, we had a seat on that, so that group was met a couple of times, hosted by the Mental Welfare Commission, and we were pleased about that. But our central point, our central worry, I suppose, still remained that there was no clear trigger point. When the Scottish Government had previously consulted on what should happen with mental health legislation in the event of a pandemic, we had very much said there needs to be some clear trigger point, so that, for example, when we reach a predefined level of staff absence, that's when we know these powers will be introduced. We didn't see any of that, and we still feel there's a lack of clarity on exactly what needs to happen for these powers to be invoked. And similarly, once they would have invoked, what would need to happen for them to be revoked? That was very much left up to the judgment of government, and we felt like that wasn't really clear enough. So we wanted a lot more clarity about those points. We do think now that the time has come for them to be reviewed, so it does seem like we're not going to need these emergency powers, thankfully, but yet they exist within legislation that lasts for 2 years. So we do think that needs to be looked at again. And certainly in previous policy work, we have called for a kind of tiered system, so that you wouldn't have all of the emergency powers coming in all at once. You could be a bit more sophisticated about it and introduce some groups of powers as they were needed. So we think there's probably quite a lot of learning from this. It might also be worth pointing out that mental health tribunals, which make decisions about whether and for how long people can be detained, are obviously currently having to operate remotely. We do understand that, but we are concerned about how well people can participate in those discussions, particularly given that they can be happening at a time when a person is really quite distressed, and trying to take part in those by telephone is really difficult. Participation is one of the principles that underpins the Mental Health Act, so it's really important that people are able to participate, and we think that probably needs to be looked at.
Thank you, that's helpful. Catherine, can I come to you now, please?
So Social Work Scotland have really, I guess, been supportive of the powers that are in the Act, but are also supportive of the fact that they haven't yet been used. And we would commend the approach from Scottish Government in relation to holding the powers in abeyance until such time that there is evidence of their necessity. We're aware that that hasn't happened by accident, and that Scottish Government have consistently had to hold the line in response to calls from some areas to commence the powers, and that we, along with the colleagues that we've spoken to in Scottish Government, have been very clear that that would represent an erosion of rights, and that the threshold must therefore be very high to move to any commencement. And by holding firm, actually, the areas that have raised the issues have found solutions. So I think the first thing is that the powers should only be by exception. However, I would also say that we're conscious that whilst the staffing crisis from an NHS perspective may look like it has passed, I'm not sure what the evidence tells us about what will happen in the autumn and the winter this year. I'm not confident that we won't see a resurgence in some of the staffing challenges both in the medical professions and in the social work professions that are also part of these processes. And whilst a number of the critical infrastructure around these decision making, such as courts and other support agencies, are not available in the way that they would be to support people, I think Social Work Scotland's view would be that we still see the value in the opportunity to bring the powers in being there for the time being. But absolutely very high threshold.
Thank you. Alex, do you wish to follow up on any of that?
I do very briefly, if I may, convener. Thank you very much for those answers. I guess before I go into my substantive question, I would like to ask Social Work Scotland exactly for a little bit more detail about those quarters that were asking for those powers to be commenced. What were the circumstances for that, and what mitigation did they find? And then secondly, given everything we know now about COVID-19 and its impact on the NHS, we know that yes, in some aspects of the NHS, some departments of the NHS are overwhelmed, particularly ITU, but actually many other aspects of this virus have created a drop-off in demand across the health service, so that whilst it's very busy in acute areas, that in other areas which might be more related to mental health legislation, demand is lessened because people aren't coming out of their homes, they aren't reporting or wishing to engage with primary care. So in that knowledge, even if there is this second wave that you allude to, are we not better equipped than we thought we were, and perhaps that we could still manage the strain and deal with things in the normal way?
Okay, thank you. So Catherine, if I can come to you first, those points addressed to you.
Absolutely. So I can't provide any specific detail around the areas. I'm just aware from our membership that in some areas they are aware that colleagues in other services have pushed for the powers to become available, and the answer to that has been no, not yet. The bar, which is an unspecified bar, has not been met. But certainly that's something that we could ask members for more detail on, if that would be helpful. In relation to the issue of demand and the profile of demand, so at the moment, what we're seeing is a change, I guess, in the NHS demand profile as the virus subsides. But what that will do is it will ease lockdown restrictions as we're moving through the different phases of recovery. And that may or may not trigger some additional staffing capacity issues as the virus becomes managed in a different way. And what we know is happening is there is a backlog of lesser priority cases around mental health legislation that are being held at the moment for courts, etc., to become more business as usual. And that includes other issues such as guardianship assessments, etc. And what that does is it puts pressure on the MHO resource, which is a social work resource held in local authorities, who are responsible for parts of those processes along with their NHS colleagues. So what we will see going into autumn and into winter is the likelihood of potentially a reduction in the availability of staff as people have to self-isolate through test and protect, etc., but also a significant increase in the volume and demand on those services at the point in time where all parts of our system are looking to get back to business as usual. So those cases that needed to be progressed several months ago haven't disappeared. That work is still there, and we know that the MHO resource is a very, very small resource, and their capacity to make that happen within a fairly tight timescale is going to be limited. So it's for those reasons, rather than capacity within health services, from Social Work Scotland's point of view, that we would urge some caution around having no legislative basis in place going forward.
Thank you. I wonder, Carolyn, do you have anything further to add on that topic at all?
I think the only point I would make is just the point I've made before about the importance of being clear about exactly when these powers can be used. So if we are to retain these powers, then I do understand, and I certainly accept that there's a lot of pressure on MHO resources. That's undoubtedly true. But I think it is really important to be clear about what are these powers for, what is the threshold when they can be used, and then how will we come out of using them, because they do have really serious impacts on people's rights.
Thank you, that's helpful. Okay, if I can move on to our next question, which is from Maurice Golden. Maurice, please.
Hi, Convener. We've covered or touched on parts of this, but the Coronavirus Scotland Act brought in provisions that would allow local authorities to disapply key principles of the Adults with Incapacity Scotland Act, and that these measures would only come into force in exceptional circumstances. I was just wondering what Social Work Scotland's views are on this.
Thank you. Catherine.
So, say that we...
Sorry, Catherine, I'll just pause you there for a second. Your sound dropped on and off. I'll just remind you, you don't need to touch the microphone broadcasting. I'll do it for you.
Okay. So yeah, our position in relation to the powers that are there to be put into play for adults with incapacity are the same in relation to the mental health side of things. So from our point of view, it is helpful to have them there in the event that the capacity issues that may arise do arise, because the reality is that if we discover down the line that we needed them, it will take too long to put them back into place if they're not there ready to be enacted and commenced. Again, we are projecting a risk of some peak demand on social work to come in the autumn and winter, where we know that we do tend to get an upturn in referrals and requests, both around adults with incapacity, but also more generally for social work and social care. And actually it's often the same staff who are doing those dual roles. So for our members, it's a comfort that should the resources be such that it is not possible to meet all of the obligations within the current legislation, that there is a fallback position. But again, we would be absolutely clear that we would not want that to be commenced unless it was a critical necessity.
Thank you. Carolyn, do you have anything you wish to say on that specific question?
Yeah, I think the provisions relating to adults with incapacity relate more to people who have dementia or have learning disabilities, so we haven't involved ourselves too much in that. I think where our other concern is, though, is about the ability for local authorities to conduct social care assessments to a less high standard than they normally would. We know from Scottish Government reporting on the Coronavirus Act that at least 5 health and social care partnerships have used those powers. And again, we understand that we're not in business as usual, so we understand there needs to be flexibility. But our concern there is similar to the one I outlined before. What we're told is that those regulations will remain in operation only while absolutely necessary to protect people. And we would like to see a lot more clarity around what does that mean and what does that look like. That's quite a loose definition, so we'd like to see that tightened up.
Okay, thank you. Maurice, do you have a follow-up on that, or are you happy?
I'm content, thanks, Convener.
Okay, Alison Harris, if I can come to you now, please.
Morning, panel. I would like to discuss the impact of the lockdown measures and what effect they are having on the mental health across different groups, and also what range of supports are in place in both the short and long term.
Thank you. Carolyn, if we can come to you first.
Yeah, so we know something about the impact of lockdown, particularly on people with mental health problems. I mean, there's been a lot of discussion about the impact of lockdown on everybody's mental health, and I'm sure many people have struggled with these strange times that we've been living in. Certainly, we did a bit of work with the people who use SAMH's services. We have around 60 social care services, and we wanted to understand what they were experiencing. We did a survey which had about 458 responses. And what we heard from people was that half of our respondents said they were feeling anxious or scared about the virus, and they talked about the disruption that it had caused, the cancellation of their activities that they would normally do, missing their friends, so that kind of thing. We also found that in terms of being able to access support, people had seen their support either switch to telephone or video support, or simply not be there at all. So we know obviously that's having an impact on people. I think the other areas where we can draw a bit of information is from, firstly, our own monitoring of how our services are working and how the people that we support are doing. We, like most social care organisations, we log incidents of concern relating to service users, and we've certainly seen an increase in sort of signs of distress. So we've seen an increase in the numbers of incidents involving self-harm, attempted self-harm, thoughts of suicide, and it's obviously we can't absolutely say that's definitely down to the impact of lockdown, but it's very noticeable that the timing of that increase coincided with the introduction of lockdown, and certainly what people are telling us is that they are struggling with it. We also know from our information service that we have seen an increase in the calls we're getting about particularly depression and anxiety, and in the number of calls we have where people are talking about suicidal thoughts or thinking of suicide. That has certainly increased, and indeed our average call time has gone up because people, although it is an information and signposting service, it's not an emotional support service. People have been looking for much more support as they try to find that information. So that's some of the indicators that we have about the effect that it's having on people.
Thank you. Catherine.
So Social Work Scotland doesn't in and of itself deliver any direct services. It's a membership organisation for social workers across Scotland, including chief social officers. So part of, I guess, the challenge is that we don't conduct research specifically ourselves, but we are very well aware of research across a range of different areas of business we've been involved in that is highlighting a significant upturn in mental health and wellbeing concerns across the whole age range. Our members are recognising that this is a particularly distressing time for people who would ordinarily receive support in a range of different places, not necessarily from social work, but from third sector, from schools, for example, respite, etc., that I heard your earlier witnesses talking about. And the unavailability of those things certainly compounds other areas of distress. And social workers across the country are certainly seeing that with the people that they support directly. That range of activity that we would usually help to coordinate and support isn't there in the same way as it usually is. So obviously the plans that we put in place to keep people safe and well don't have the fullness at the moment that they would usually have, and that will not be without its impact on people's ability to cope. And I think the other thing I would just add for the committee's information is that there is an upturn in the number of adult protection concerns being in some areas, which is, I think, a clear indicator that some adults certainly are also struggling with lockdown and the impact on themselves emotionally.
Thank you. Alison.
Well, I now would like to discuss, the reduction in the support services. What does this actually mean for the mental health clients in the community? And what about the pressures it's actually putting on the staff at this time? Have you any more information on that, please?
Is that to Carolyn?
Yes, please. Sorry.
Carolyn.
Thank you. Yeah, what we've seen in particularly talking to the people who use SAMH services is that certainly people are not getting the services that they would normally get, and there's not really at this point a lot of information about when those might resume. Although I know we saw a statement from the Minister yesterday about some moves towards resuming services, which is very welcome. We certainly saw that around a third of the people we support said that their NHS or related support had moved to video calls or telephone calls. Around about 15% said that they hadn't had any contact at all with their usual contacts. So that might be a community mental health team, it might be a CPN. That's obviously quite worrying because those people don't really know what's happening. They don't know when anything's going to resume, and they are they're operating without the support that they would normally have. I think a really important point is about access to technology. So we have seen in some cases support begin to switch to telephone support or video support. Indeed, we've done that with our own provision of support. But we know that from the survey we did of our service users, around a quarter said they didn't have access to or know how to use technology. We're certainly bearing that in mind as we go forward. And I think it's really important as we move towards the resumption of services that we don't assume that everything can be delivered online. We know that leaves out a big group of people. So I think that's going to be really important as we go forward. I think more broadly, I mean, we certainly are expecting that there is going to be an increase in demand for mental health services. We've seen, for example, the financial crash in 2008 led to an increase in need for mental health support. There's also some evidence from previous pandemics that it has impact on people's mental health. So we're certainly expecting that there will be increased demand that we need to try to be there to meet, as challenging as that might be. People are going to have quite serious mental health needs going forward, and particularly those people who were struggling with a mental health problem at the start of this and have now had to go through lockdown, perhaps a lot of isolation, uncertainty, anxiety. There are going to be some quite serious needs there.
Thank you. Catherine, I know your organisation doesn't work directly, but do you wish to add any comments on that?
Yeah, so I'm aware from our discussions as an organisation that the majority of social work services are using technology very heavily at the moment to sustain and maintain contact with the most vulnerable people that we work with. We're still receiving referrals and we're still conducting assessments, and there was earlier reference to the ability to conduct a lesser depth of assessment and the limited way in which that has been used across the country, and that would relate to people with mental health issues as well as a whole range of other social services related referrals. So people are working very hard to try and maintain contact, but the reality is that actually some of the supports that people with mental health needs at most rely on are community-based support services who have not been able to operate fully in the current climate. Access to physical exercise, social gatherings, and all of those things, of course, have not been possible recently. So we're again aware that that package of support and connectivity to others that we would usually promote and encourage hasn't been as available as we would have liked. And that's meant a very different kind of reliance on one-to-one type support, often, as the earlier panellist mentioned, by telephone or other digital means. And that certainly does have its limitations, although some people have responded very, very well to that, and it suits them to communicate like that. It is not for everybody. And there is nothing that replaces the face-to-face connection and the building of a relationship to support people through very difficult times.
Thank you, that's helpful. Can I go to Angela Constance now, please, Angela?
Thanks, Convener. I have a couple of questions for Catherine Lindsay. On Social Work Scotland, I should, of course, declare an interest as a former social worker, practice teacher and mental health officer. I'm particularly keen to understand more about what it's actually like for frontline statutory social work staff working throughout the pandemic, in particular in relation to carrying out assessments. And I note, Catherine, that in a Social Work Scotland briefing that was prepared when Parliament was debating the emergency legislation, you expressed big concerns about the removal of Section 13ZA from the Social Work Scotland Act 1968, which was about taking out the need to take into account the views of adults and other interested partners. My view is I don't know how anybody can do an assessment without taking on the person being assessed, even in an emergency situation. Of course, professionals don't necessarily have to, on balance, agree with the views of their clients, as long as they can justify it. I just don't know how anybody can do an assessment without listening. So I would be interested on your views on that, and also just quickly whether there are enough returners to services, and if adult protection cases are increasing, are we also seeing an increase in child protection cases? And is there anything else we need to do to prepare for winter? Thank you.
Thank you. Catherine.
Thank you for that. That's a fair list from a fellow social worker, so thank you. So firstly, you asked what it is like for staff on the front line, and I think whilst we don't represent a broad base of frontline social workers, it's important to say the majority of our members are in managerial posts. We obviously have feedback from our staff and we discuss the challenges on a regular basis. It's very difficult. It's very difficult operating a social work service when the majority of staff are working from home. There are issues about confidentiality. Our staff, like other professionals, are currently trying to juggle often other caring responsibilities and homeschooling with the delivery of a front-end social work service. So that is a fairly unique context for the delivery of social work, and I commend our staff for the energy that they're putting into doing that. There have been some challenges that we're aware of across the country around people's digital ability to be connected enough to do their work from home and to facilitate and support that. Some local authorities have got very good digital infrastructure. Some geographic areas obviously struggle with digital connectivity more than others. So there's bits about hardware, but also the IT infrastructure more generally that has made it challenging in some areas. So I think the other thing I would say is that our staff have, from the outset, continued to see people face to face. So whilst a lot of work is happening from a base that is home, people are still going out into communities and into people's homes, and they are doing that to make sure that people remain safe. So there's no desire from social work not to be absolutely front and centre in communities and supporting people through this difficult time. I think in terms of the specific question you raised about 13ZA, so I should declare that I'm not a mental health specialist whatsoever. But I am aware that we've had a lot of discussion and we were very concerned about this at the outset, and were very strongly worded, I think, in our letter around our concerns at the outset. As things have progressed, it hasn't emerged as a significant concern, and I think part of the reason for that may be that hospitals have not been as overwhelmed in terms of space as it was perhaps anticipated they may be. And so that urgency of moving people out of hospital without that full rounded assessment of people who may not have capacity to share their views and whose views cannot be ascertained, that hasn't presented itself as a significant volume issue across the country. And I think that is reassuring. And chief social work officers individually, we're keeping a very close eye on that because we are very much of the view that people's views need to be heard and need to be taken into account in terms of decision making about care. I think you also asked about returners to services, and I just would like to clarify, is that in terms of the opportunity for people to come onto the temporary register?
Yes.
So there haven't been, as far as I understand, and I don't know the national figures for this, but not a massive uptake. There were a number of people who have come forward and said that they're prepared to do certain tasks in particular areas, and that they have joined the SSC register. We've also had a number of qualifying social workers, so who would become newly qualified social workers imminently joining that temporary register. Local authorities who are where most services for social work are located still have to go through their own recruitment process in order to deploy any of those staff. Because we're not a national service, there's not a kind of central infrastructure around that. So local authority areas are very much still looking at what staffing capacity they need and what they have budget to pay for, and then recruiting. But it's certainly helpful to be able to see at a glance from the SSC who is available in your area and keen to be taking on work. And what that means is that we can promote the fact that we've advertised the job to those individuals. And so, hopefully they won't miss the opportunity to come and work with us. I think there was another facet to your question, Angela, but it's gone out of my mind.
Angela, you had mentioned, Catherine, that there was an increase in adult protection cases, and I wondered whether there was also an increase in child protection cases.
Yeah, absolutely. Sorry. So there's weekly data collected by Scottish Government. I understand that is then provided as a composite report. What that is showing is that in the very initial weeks, there was a significant drop in the number of child protection referrals across the country. But what we've seen is a fairly steady increase again over the last few weeks. And a number of areas are starting to report the underlying referral rates to social work, so not just child protection concerns, but the referral rates are starting to climb. And that what we are concerned about, and that was the final part of your question, I remember now, is what does this look like then into the autumn and the winter months? And certainly in Social Work Scotland circles with a children's services hat on, we are mindful of the plans for children to move back into schools in the early autumn period, and that what we know will happen at that point is children's exposure to a wider range of people with whom they can share their worries and concerns is likely to result in some concerns being referred to social work. So what we're anticipating is an upsurge in referrals in around August, when more children start to have more access to a wider range of adults with whom they might confide. And in relation to the winter, I guess in terms of the earlier comments around what we don't know about this pandemic and how it will behave, I think we are all also kind of sitting and hoping that there won't be a perfect storm of capacity in the autumn-winter months with our ordinary flu season. And the opening of other organisations that will see an upsurge in social work activity being required and reinstated for the last few months, with also a coronavirus upsurge. So we're very concerned about the end of the year.
Okay.
Angela.
I'm content, convener, thank you.
Thank you. If I can come to Fulton McGregor now. Fulton.
Thanks, convener, and good morning, panel. Following Angela's lead, I should also declare an interest as a registered social worker, and my partner is a practicing MHO as well. I wanted to ask a wee bit about changes to social care support, and if I could start off by asking the panel what steps you think should be taken to make sure that the people get the social care support that they need, particularly at this time of crisis.
Thank you. Adeline, can we come to you first, please? Oh, we seem to have lost your sound again. No, I think we'll need to... Can you try and speak again and we'll see? I wonder if we can go to Catherine and if broadcasting can try and sort your sound out while we're hearing from Catherine. Catherine.
Thank you. So in terms of social care support, I think part of the challenge is financial support for funding for social work and social care across the piece. And there have been additional monies which have been absolutely welcomed. But at the same time, we know that there's likely to be a significant upturn in demand. And I think most local authority areas and health and social care partnerships were already saying, actually, there's not enough money in the pot to start with. We're very concerned, as with the other panel member, about the likelihood of an upturn in mental health and wellbeing issues that may well then result in an upturn in the referrals to social work and social care for different kinds of support. And certainly in relation to capacity, that will be a challenge to meet existing need and growing need. But the money is only one part of it, and I guess the other part that we are concerned about as an organisation is the lack of capacity in the system in terms of
Well, now we seem to have lost Catherine as well. I think what we'll do is just suspend briefly while we try and fix this. Welcome back. We just, Catherine, we were with you responding to Fulton Gregor's question.
Yes, I'm sorry, I don't know what happened there. So the other point that we would make is about the availability of a workforce, and we know that there's been a high-profile campaign around certainly recruiting to social care, but the social workforce itself is also a fairly limited pool nationally, and we would welcome any support to grow that from Scottish Government in terms of funding and support for social work students, for people to take the decision to move into a career as a social worker, because at the moment that's a very challenging decision for people to make, certainly as a second career, which used to be a route of choice.
Thank you. Carolyn, do you need Fulton to recap on his question, or did you manage to catch it before we lost you?
Thank you. I did hear the question. I missed one or two of Catherine's points, so I apologise if I repeat anything that's been said. I certainly heard Catherine talk about the importance of funding and of there being the workforce there to provide a service, and absolutely we would certainly agree with that. I think what we know is that the effects of coronavirus are not going to be equally felt across populations. So people who have existing mental health problems are likely to be more affected, as are people who are working in the health and social care sector, or people from BAME groups. So I think one of the things that's going to be really important in making sure that care is there for people is actually understanding who needs care and what the baseline is. I heard the Minister yesterday, the Minister for Mental Health, talk about asking health and social care partnerships to establish a baseline of actually what has been happening with services, what is available now, and what needs to be rolled out. So I think that's really welcome, and that's going to be really important. We do know that we're going to need good data in order to manage this, and I think there are probably a few areas where we need to look at that. One area in particular, we are worried about the impact on mental health of this. We're worried about any potential for an increase in suicides. We have noticed that there is currently no scheduled date for the publication of the annual statistics on suicides. They would normally come out in the summer, and we're a bit worried about that. So we would like to see not just the data about the resumption of services, but actually the publication of data. So when is that particular information going to come? And I think the other point that's probably worth making is that obviously a lot of social care is delivered through the third sector, and we definitely need to see the third sector being involved in the discussions that are going to be taking place now about trying to get services. I don't want to say back up and running, because I know they never stopped. Certainly our own services did not stop throughout all of this, but back on a more normal footing. So I think it's going to be really important that we have genuine cross-sector conversations about what is being provided and what still needs to be provided. The mental health needs are going to be substantial, so we do need to work together to make sure that we can meet those.
Thank you. Fulton, do you have any follow-up questions?
Yeah, thanks, Convener. I think that in relation to sticking with social care support, there's been a lot of talk about that we're perhaps over the peak just now, and the care plans are beginning to return to some sort of normality, very, very slowly, of course. But there's also been a lot of talk about there being a second wave later on in the year. So I just wonder what the panel think we could do as a society to make sure that we're more prepared for that in relation to social care plans. Do you think that essentially we could do things differently so that people are more supported if, I mean, fingers crossed there isn't one, but if there is to be a second wave later in the year.
Carolyn, can we come to you, please?
Thanks.
I think that undoubtedly we can take learning from this. I mean, this has been something that none of us have ever gone through before. So of course we're going to be able to learn from it. I think from our point of view, hopefully, I really hope there isn't, but if there is any kind of second peak, we can be better prepared with communicating with people about what services they currently receive, what's going to happen to them. I mentioned early on the 15% or so of our service users who said they'd just heard nothing about what was happening to their services. So I would hope that we can do better about that and communicate with people really clearly about what's going to happen, what is going to be possible, what isn't going to be possible, and particularly about what's going to happen once things start to get back to normal again. One of the concerns we've had has been about, is there an expectation that people who needed support and weren't able to access it during this period, that the onus is entirely on them to go back to the beginning of that process and start seeking support again? So can we do better on, if we absolutely cannot support people during a period of crisis, can we at least make sure that it's not entirely up to them to restart that process of seeking support? So I think probably communication with people about what is possible, what's happening, what the timescales will be, and also seeking to make sure that as much as possible support is provided through digital means, while recognising that just does not work for quite a lot of people with mental health problems.
Thank you. Catherine, do you wish to comment on that?
Thank you. So I think I would agree there are definitely things that we can learn, and this is not something that any of us had to plan for previously. I don't think we could have anticipated the responses that would be required at the volume that they were. I mean, I think what would be helpful from Scottish Government going forward would be some indication of how they may plan to respond to any second wave of infection, whether we would see a return to lockdown and how that might look. And I think we're in a better position in the sense that our workforce have got an understanding of how we might respond as employers and what facilities they might have available to help them sustain the support that they deliver for people. So we would, I guess, spend less time trying to get our heads around all of that and put the infrastructure in place, provided we can maintain that infrastructure with funding going forwards. And I think that we're in a better position as well in relation to how PPE interrelates with the activities that we undertake, that there is PPE available for a wider range of services than would have previously needed it in the past. And so the effort and the energy that went into the very initial weeks could be used very differently if there were a peak. And I would very much hope that we would be able to provide a greater degree of clarity and certainty for people who use our services around what the impact of any future lockdown, or certainly staff shortage caused by any peak, might actually necessitate in terms of their packages of care. I think we need to have the conversations with people now about how we would approach that up until the point where the virus is completely gone, or we have some sort of inoculation against it.
Thank you. That's really helpful. So that concludes our evidence session this morning. Can I thank you both for your evidence and your time. Certainly a lot for the committee to think about and act on. That concludes the public part of this morning's meeting. At our next meeting, we'll take evidence from the Minister for Older People and Equalities, and meantime, any follow-up scrutiny issues will be dealt with by correspondence, which will be published on our website. As previously agreed, I now move the meeting into private session, suspend the meeting, and we will reconvene on MS Teams.